Good morning, everyone. Good afternoon for anyone joining east of Winnipeg. Welcome to our CANUE expert webinar. My name is Alan McKee. I'm the communication specialist for CANUE, which is the Canadian Urban Environmental Health Research Consortium. I want to start by acknowledging the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Before we get started, I'd like to remind you to please turn your cameras off and stay on mute during the webinar. If you have questions during the presentation, please put them in the chat and we'll have time to answer them at the end of the webinar. It's my pleasure now to introduce Haneen Khreis, who is a senior research associate in the MRC Epidemiology Unit at the University of Cambridge and an associate scientist with the Texas A&M Transportation Institute. She's a cross-disciplinary researcher broadly studying the health impacts of transport planning and policy with a special interest in cities. She's trained in transport planning and engineering, vehicle emissions and air quality monitoring and modeling, systematic reviews, health impact and burden of disease assessment. She also has expertise in policy options generation and the science policy link. Haneen has worked extensively with air pollution and asthma in particular, doing epidemiological burden of disease assessment and monetization studies. She has published over 70 peer-reviewed papers, chapters, and technical reports with a large media impact and edited 3 books on integrating human health into planning, transport and health, and traffic-related air pollution and health. Haneen recently developed a cross-disciplinary course titled Traffic-Related Air Pollution, Emissions, Human Exposures, and Health. She's dedicated to improving human health and equity through supporting relevant education, workforce development, and evidence-based healthy and just planning. We were especially excited to have Haneen speak about her research because her work dovetails really nicely with a new initiative here at the University of Toronto. Positive Zero Transport Futures is a project that has been funded for 3 years that will facilitate interactions between transportation and the physical and social environments, as well as explore core aspects of transportation science, its living lab approach for real-world testing of innovations in transportation, and its broad community of industry, government, nonprofit, community groups, and academic partners will together enhance knowledge exchange around solutions to accelerate the pace of transport decarbonization. It will also enable unique experiential learning opportunities to a new generation by establishing a collaborative, transdisciplinary, multi-stakeholder research program and by facilitating internships within partner organizations. As the project is focused on enabling transport innovations with zero emissions and positive social outcomes, we're very lucky to learn from Haneen and her research into the pathways between transportation and health. And so with that, I will turn it over to the person we're all here and excited to hear from. Haneen, thank you very much for making time to participate in our webinar series. And I will stop sharing my screen and the floor is yours.
Okay. Thank you so much, Alan, for inviting me for this talk, and to my friend, Jeff Brook. I think you're online as well. Yeah, I appreciate the opportunity to talk to all of you today, and thank you all for making the time to be on this presentation. So as Alan already introduced me, my name is Haneen Khreis. Let me start by putting this on presentation view. Can you all see my slides?
Yep.
Okay, great. So my name is Haneen Khreis. I recently joined the MRC Epidemiology Unit from Texas A&M Transportation Institute. I'm still actually involved with TTI as an associate scientist on some select projects. So I'm still affiliated with them, but my primary affiliation right now is at the University of Cambridge. What I want to talk to you today about is the links between transportation and health. And I thought yesterday more about what I want to present today. And I think I want to preface this by saying that I thought it might be more interesting for this crowd to look at a higher level description of these pathways between transportation and public health, talk about equity and the intersection with equity, and show some exercises where we quantify the impact, the public health impact of these pathways. And I will show an exercise from my old job at Texas A&M, where we looked at the burden of premature mortality from noise, air pollution, and crashes in Houston, Texas. And I will show an example of a project that I'm involved in at the University of Cambridge, which really brings something new to the discussion and to the table, because it looks at low and middle income countries. We're looking at Central and Latin America. And as I will say later, a lot of the burden of disease and health impact assessment exercises so far have been limited to high income countries. So I'm hoping to talk for about 45 minutes and then open the floor for discussion and questions. So the first part of this presentation is on the pathways between transportation and health. I want to acknowledge funding that we received to do this work from the US Department for Transportation under CAR-T, which is the Center for Advancing Research in Transportation Emissions, Energy and Health, where I was before I joined the University of Cambridge. And I want to acknowledge Andrew Glazener and Suhail Sohrabi, who worked very closely with me on this work. And I also added here a link to the report where you can find full details on the modeling and the creation of the conceptual model that I'll show you next. So there's a lot more information that I really don't have time to get through. But for people who are interested, they can find full detail on this link, which we can share after the talk as well. So the first thing I want to talk to you about is how we think about transportation and health. And I think there's been progress in the past decades in terms of how we see these interactions or these linkages. And perhaps if we think back to the past, some of the more recognized linkages were related to road travel injuries. So these are some numbers that I'm showing from the World Health Organization that give an indication of the impact of these pathways on public health. So for road travel injuries, it's a pathway that's really, I would say, well recognized, and to a big extent, it's considered in transportation planning and policy, or road safety, as you know, it's mentioned often. And the impacts are at this level, 1.3 million deaths and over 80 million injuries resulting from road travel injuries. And I will say here that these effects are mostly affecting vulnerable road users. So these are pedestrians, these are cyclists. And the other not so great statistic is that 50% of all traffic deaths occur in underdeveloped or low and middle income countries, while in reality, they're responsive, or they have a very small share of motor vehicles. So there's a huge inequity element there. The other two pathways that I think are relatively well recognized that link transportation to public health are ambient air pollution and physical inactivity. And these are general numbers that I'm sure some of you have seen before. So ambient air pollution is estimated to be responsible for 4.2 million annual global deaths, and physical inactivity in 2.1 million annual global deaths. And these estimates, at least for air pollution, may be conservative. And there are estimates actually that come from Rick Burnett in Canada, who has used a different methodological approach to estimate the attributable burden to ambient air pollution, and found over a doubling of these impacts using his new method. Transportation-related air pollution, its contribution to this burden is also something that relates to methodology, and there is some uncertainty in it, but these are some numbers from a relevant study. So 1/5 of attributable premature deaths in the UK, the US, and Germany may be specifically attributed to traffic. And a lot of people don't breathe what we might call safe air. So they are in, most of us are in areas where the WHO air quality guidelines levels are not met. And globally, 1 in 4 adults are not active enough. Now, what we've been working on for the past couple of years, and this is the original paper that people can go and relate to or go and refer to, is thinking beyond these 3 pathways, which are really important, but the reality of the linkages between transportation and health is different, and it's much wider. And I want to spend a few minutes taking you through this conceptual framework that we came up with, looking by scanning the literature, by discussing amongst each others and talking to experts in the field, and building on a lot of our work over the past few years. So this is a conceptual framework that basically frames the linkages between urban and transportation planning and public health. And it has 3 different levels, and I'll show you these 3 different levels briefly. So the top level here, we have 4 kind of distinct boxes, and each of them represents an element of urban and transportation planning and policy. So we see land use and the built environment, we see transportation infrastructure, transportation mode choice, and transportation technologies and disruptors. And as you know, these things are not mutually exclusive. So the way that our land use is and the built environment is will have an impact on which mode we choose to travel by, which modes are safe, which modes are desirable and convenient. And likewise, transportation infrastructure can result in feedback loops to land use and the built environment by making them more compact or making them perhaps more sprawled, as we see a lot in North America. And likewise, between all these 4 different boxes, there is a lot of interaction, but we like to think about urban and transportation planning and policy within these terms. And we have equity as an overarching theme across this whole framework, which you can see to the left in this graphic and in the graphic above, because these different exposures and these different kind of elements of transportation are not equally distributed. And I will talk more about this later on, and I think it's perhaps easier to understand when we talk about pathways to health. So at the second level of this framework, we have the different pathways to health, which you might think of them as transportation-related exposures or lifestyles, but things that can be either beneficial to health or detrimental to health. And a lot of thinking, I will say this, that a lot of thinking and a lot of discussion has gone into this framework. And we finally came up with 14 pathways to health, which you see on this figure. On the left side of the graphic, you can see the ones that are beneficial to health. So these include increased exposures to green spaces and aesthetics, increased physical activity, increased access to health promoting opportunities. So things like access to healthcare, things like access to physical activity and to parks, and mobility independence. So being able to basically meet your transportation needs and your access needs on your own, which has impacts both on motor skills development in children, but also on cognitive function, especially in older adults. On the right-hand side of this graphic, you can see 10 pathways that have a detrimental impact on health. So increases in these pathways have been associated with increases in premature mortality and morbidity. And as I said, air pollution and crashes are some of the more well-known ones. And the quantified, the well-quantified ones as well. But some of the other ones include contamination. So this relates to water or surface water runoff. And when it gets to our food, to our soil, to the water we consume, social exclusion, traffic noise, which I have a section in this presentation that will deal with traffic noise, urban heat, or the urban heat island effect, as some of you might know it, community severance, electromagnetic fields, stress during commuting and in congestion, and then greenhouse gases. Not just, so when we think about greenhouse gases, we're not thinking about it here as a co-benefit to health promoting policies, but we're rather thinking about the long-term implications of climate change on health and well-being and mental health. So in this slide, what I did is I highlighted those pathways where we have now, I think, enough evidence or a lot of evidence that we can quantify the impact of these pathways on public health using standard burden of disease and health impact assessment. And I will show some of these exercises, but this is just really to kind of give an indication on what we know and what we don't know just yet, or what we don't have enough data and enough methods and tools to quantify. And I guess, yeah, I'll get back to equity in a minute. The final level of this framework is related to the public health impacts of these exposures or these pathways. So as I already said, they have been associated with increases in morbidity rates across a really wide spectrum of diseases, and also with premature mortality. And what I have here is what we call effect modifiers, and I'll talk about this in just a second. So in terms of these pathways and how they intersect with equity, we do have equity as an overarching element in this framework, because it really is. Because it is at the first level where we know the transportation infrastructure is not distributed in a way that is equitable. When we think about it, or when we look at the literature, there is a clear socioeconomic gradient. And even with race and ethnicity, we see that people who are from lower socioeconomic backgrounds or from ethnic minorities tend to live near major highways. And with that comes a lot of things like increases to air pollution and traffic noise and the risk of travel injury. So this is a study from the whole of the United States that basically shows that when you compare census tracts with low road and traffic densities to ones with high traffic densities, so the 25th to the 75th percentiles, you find that the percentage of Black and Hispanics are more than twice as high in those higher density traffic census tracts. And this is relatively well known. I think this is well established in the environmental justice literature. And we also looked at this across the United States when we looked at the impact of air pollution on children's asthma. And these are some of the figures that are perhaps too busy to make so much out of them here, but I'll move to the next slide, which should be clearer. So what we're looking on this figure is the distribution of the burden of childhood asthma related to nitrogen dioxide in the United States. And we stratified these impacts by median household income. So that's what you see on the x-axis, and on the y-axis is the burden of disease. And what we saw in the United States, which is also in line with what other people saw and did, is that there is a gradient in many states. For example, if we look at Utah, you can see that the poorest or the lowest groups with the lowest median household income, they have the highest burden. But we also saw a lot of heterogeneity where, for example, in New York and Texas and some other states as well that are not shown here, The poorest and the richest census blocks have some of the highest impacts. And this is something that we wanted to look more into, but we thought it might be related to those more wealthy groups being able to live in busy areas in downtown. So this is a well-established kind of picture in the literature, in the environmental justice literature. We replicated it, some others replicated it. I think the thing that we still don't know too much about is not just, I will stop and say that the results that I just showed are driven by two things. They're driven by the mortality rates in those different areas, and they're also driven by the different exposures in those different kind of household median groups. But we don't account for individual susceptibility in these estimations. And individual susceptibility, what it means is that an individual or a group may have an enhanced responsiveness to an identical level of exposure compared to those who are less susceptible. And susceptibility can be impacted or driven by many factors. I've listed some of them here. But we don't have exposure response functions for these subgroups. So everything that we do so far, or at least that we've done so far in health impact and burden of disease assessment, doesn't account for this. And I think if we do, we might also see increased burdens in some already very vulnerable groups. So in this next section, I want to talk about two examples of quantitative burden of disease and health impact assessments. And before I show these examples, and I'll talk a bit about the methods, but mostly about the results and the messages, the key take-home messages. I will say that we like to do these exercises because they can help in many ways. So burden of disease and health impact assessment exercises. They can potentially support communication. They can potentially support influencing policies, because they can do some of these things, like attributing the health burden to specific exposure sources, like investigating the potential impacts of counterfactual scenarios, which is what we do in the next examples that I will show you, but also looking at different policies and different technology scenarios. And they provide, the nice thing about them, or the useful thing about them, is that they do provide numeric indices or estimates of the burden of premature mortality or of morbidity, so of disease, that we can use in things like cost-benefit analysis or other ways to do economic assessments. And I think they're also a nice way to engage with stakeholders and catalyze the public's understanding and influence policy action, where I think, and that really happens when the policymakers are receptive to looking at these indices or these estimates. So the first example, or the first case study, I actually cut this down a bit just before the talk. So I will show the impact of noise and vehicle crashes on premature mortality in Houston. And the example after that, it will be in Central and Latin America. And both of these examples, they share a methodology with some differences that I will highlight that I think are important differences. But overall, the general methodology to do these exercises looks something like this, which I would say this is a standard burden of disease or a health impact assessment framework, where you go through multiple steps to get to the attributable mortality or morbidity at the end. So what we do is we pick the hazards that we're interested in, or the exposures that we're interested in. So in this case, we'll be looking briefly at air pollution, we'll be looking at noise, we'll be looking at physical activity, and also on crash risk. And then we look at differences between counterfactual scenarios and the baseline scenario. So what we currently have at hand and how these exposures might change if you introduce certain changes to planning or policy or mode shift. So think again back to that conceptual framework, so the very first level of that conceptual framework. What would happen to the exposures or the pathways if you change things at that first level of the conceptual framework? So after we look at the exposures, and these can be individual exposures, like the case of the Latin American case study that I will show, or they can be mean population exposures that are usually assigned at geographic levels that are appropriate. So things like the census block in the US or the census tracts. So the first thing, we look at the exposure, we find out what are the exposure response relationships between these different exposures and the health outcomes of interest. I will be only showing some results for premature mortality, although again, the range of potential health outcomes is really wide. And then we scale the relative risks or those exposure response functions for the exposure difference between the baseline and the counterfactual scenario. And then we use those scaled exposure response functions or relative risks to calculate what we call a population attributable fraction, which I'm sure many of you are aware of. But basically, the population attributable fraction is the proportional reduction in mortality, in this case, that would occur if exposure to a risk factor was reduced by a certain amount. And to be able to calculate the population attributable fraction, we only need the relative risk. And then the next step would be to calculate or estimate really the attributable mortality and morbidity, which is the population attributable fraction by the baseline rates. So these are the rates of mortality in the study area because of all causes. So not just related to air pollution or noise or green space, but just the observed mortality rate in the area of interest. And we also use population counts. So yeah, it's a relatively straightforward framework, although the data needs can be problematic sometimes. And I will say this before I get on with the two examples, is that the main difference between these two is that one looks at individual exposures and individual changes in travel, and the other just looks at exposures at the census tract. So for the first case study, we've done the study in Houston, Texas, which is the largest city in Texas, and it sits over 1,700 kilometers squared. It's located in 3 different counties. We had mortality rates for these 3 different counties that we used for this exercise. We cut our area into census tracts. We use census tracts as the unit of analysis in this work. And we had 592 census tracts. And we used this age, so 75 years old, as a cutoff for premature mortality. And just for reference, in the US, the life expectancy is 78. We use 75 just because of the availability of data. So going back to the framework and thinking about where everything fits in, so these are the input data that we needed: population counts, which were freely or publicly available from the Census Bureau. We found out also what the premature deaths or how many fatalities are related to motor vehicle crashes in Houston. This is observed or reported data that we just needed to extract from FARS. For each crash, we had a location and we had an age. So we can distinguish between those ones that we would consider premature mortality and those ones that we wouldn't. And we assigned those numbers again at the census tract level, which was our main unit of analysis. And then the other data that we needed for this exercise, so the next thing would be the exposure response functions or associations from the literature. And we just scanned the literature and found appropriate exposure response functions for all-cause mortality and air pollution. These came from a World Health Organization report that had specific numbers for the US, which we used. And then for cardiovascular premature mortality, those were the outcomes that are related to transportation noise. Both we looked at traffic noise and aircraft noise, and we got those from a Swiss study, a large Swiss cohort that controlled for air pollution as well. So in terms of the exposures, we didn't do our own exposure calculation. We just used the Federal Highway Administration transportation noise maps that are available for the US. This is how they look like. They're done at different spatial scales for road traffic noise, which is the map to the left, and a different scale for aircraft noise, which is the map to the right. And what we did basically is we overlaid these maps with the census tracts and intersected them, and then distributed the exposure based on population, which we assume that it's uniformly distributed in each of the census tracts. So yeah, I think as I prefaced, there's a lot behind these calculations and a lot of decisions, but I think the more interesting part here is the results. So I want to jump right into it. So this is how our results look like. We looked at the age group above 30 years old and below 75, which is the life expectancy cutoff that we used. We had a counterfactual scenario where we asked how many deaths are attributable to transportation noise if we estimate this for levels above 35 decibels, and I'll show you what 35 decibels mean in the next slide, I guess in real world terms. And then we looked at cardiovascular mortality and then myocardial infarction and heart failure with road traffic noise and aviation noise. And these are the numbers that we came up with using that exercise. So with road traffic noise, we attributed 215 deaths to the current exposures or the baseline exposures in Houston. And for aviation noise, we attributed 52 and 35. And the total of these deaths is 302, which if we look at the premature deaths from motor vehicle crashes in Houston is 330. So that was something that jumped at us because we didn't realize at the time, I guess, the extent of the potential impact of traffic noise and that it can be comparable to those premature deaths from crashes. Although, of course, very different ways of coming up with these numbers. But I think I would say acceptable ways. So in context, what does this really mean in context? So the rate of premature deaths related to transportation noise is 3.6% of overall deaths in Houston. And these are just some numbers to put this number in context. So for example, for diabetes in the US in the same year of analysis, there were 2.9% of deaths related to diabetes and then over 4% of deaths related to Alzheimer's disease. And that 3.6% is larger than the death rate from the flu, pneumonia, or suicide in the US in the same year. We also did the same exercise for air pollution, which I didn't show here. But again, to put the numbers in context, air pollution in Houston was estimated to result in 7.3 premature deaths in the same study year. Sorry, I'm just checking how much time I have left. So the next and final part of this exercise was that we looked at how those premature deaths were distributed by household, by median household income. And these are the figures which we separated by aviation noise in red, road traffic noise in orange, and green is the combined effect. And as you can see, with road transportation noise, we see an impact or a distribution that is somewhat similar to that of air pollution. Actually, slightly less similar. With air pollution, it looks much more like a U kind of shape, where you have the highest burden in the lowest income group, and then also a high burden in the highest income groups. Here, it's a bit less clear, and with aviation noise, it's also less clear. But we were interested in this question because we wanted to understand better the distribution of these impacts across our population. So that was our Houston case study. The next thing I want to move to is a case study using the Integrated Transport and Health Impact Modeling Tool, or ITHM. Some of you might be familiar with this model. And I also added a link here where you can find much more information that I don't have time to get into during this talk. So some acknowledgements. This model was pioneered by James Woodcock from the University of Cambridge. It undergoes ongoing development, and part of its development right now is funded by a European Research Council grant that we're part of, called GLAST, or the Global and Local Health Impact Assessment of Transportation. As part of this work, we're looking at, as I said, Latin American and Central American cities, but also global cities, where there hasn't been burden of disease and health impact assessments in the past. And I think that's a really important contribution of this work. And I want to thank my colleagues, Ali, Dan, Lambed, Rahul, and Anna for also being part of this development and those results that I will show you next. So what we did here is we applied ITHM Global, or we used ITHM Global in 20 cities across Central and Latin America, which you can see here on this map, to look at the impacts of counterfactual transportation scenarios. And I'll talk in a bit about what those are. But in terms of the cities that we looked at Buenos Aires, we looked at 2 cities in Brazil, we looked at 12 cities in Chile. We had a lot of information there. 3 cities in Colombia, 1 in Mexico City, and Montevideo. And I'm not sure. I mean, I've seen some work coming out from Mexico City, but I think there's really a lot of missing information from some of the other cities. So the way that this model works, a lot of it overlaps with the description I already gave on burden of disease assessments or health impact assessments. And it looks at 3 pathways. It looks at road collisions and fatalities from road collisions. It looks at changes in air pollution and premature deaths from air pollution. It also looks at physical activity, and we're working to add CO2 as well, or changes in emissions of CO2 as part of the modeling. And I'll focus on all-cause mortality in this presentation, but we also have results for cause-specific mortality elsewhere that I won't get into. And the only thing that I will say on the methods, not to spend too much time on it, is that a lot of these calculations are underpinned by travel survey data in each of the cities that we included. And from those travel survey data, we get things like what is the mode choice, the percentage of trips done by the different modes, what is the distance traveled by different modes, what is the travel time, which is important when we think about things like air pollution, like being on a bike for a longer period of time and inhaling air pollution over that period of time. And all of these calculations are done at the individual or at the person level, or what we call microsimulation, and then is scaled up to the population in the different cities. So some overlap with kind of what we did in Houston, but the big difference being that this is at the individual level. So the question that we asked in this exercise is, what would happen to health impacts from air pollution, from collisions, from physical activity, if we change the mode choice percentages in those cities? And to do that, we created 3 different scenarios. And I don't think it's too interesting to get into this right now. So just like very briefly, we had 3 different distance bands. One of them is 0 to 2 kilometers, one is 2 to 6 kilometers, and one of them is 6+ kilometers. And we basically changed the mode percentages in each of these distance bands in a comparable manner, and came up with 3 different scenarios. One is increasing driving, one is increasing cycling, and one is increasing public transportation. And I can talk more about these scenarios if people are kind of more interested in how we came up with them. But the key idea was to figure out what are the trade-offs, what are the health impacts if we increase cycling in those cities, and if we increase driving, and if we increase public transportation. So to jump right into the results, and I will say that these are draft results. This is just work that we literally just finished. So there might be changes. We're looking at different aspects of the work, but these are the numbers or the estimates that we have right now. And here we're showing the health impacts, the public health impacts of the cycling scenario. And I'm not showing the 20 cities, I'm showing the 6 largest cities out of those 20 cities. So these are Belo Horizonte, Bogota, Buenos Aires, Mexico City, Montevideo, and Sao Paulo. And as you can see, and this is in line with other literature as well, that there are trade-offs in the health impacts of increasing cycling in those cities. The big benefit comes from preventing deaths from increases in physical activity. And I think this is a really important benefit. And again, this is in line with the literature in general in other areas. The potential harms come from increases in air pollution exposure, specifically for the people who uptake cycling or the new cyclists, and road collision deaths because of increases in risk and because of cycling being a vulnerable group. But overall, I think the picture is that there is a net benefit across the 20 cities. And if you look at the numbers across the 20 cities, we're estimating that we can potentially save over 1,000 premature deaths by increasing the uptake of cycling in those cities. The second scenario is more grim. It's increasing driving, and while in some cities it can reduce the risk of motor vehicle crashes and therefore reduce road collision deaths, the overall or the net effect is harmful. And that's because of reductions in physical activity and increases in air pollution in the general population mainly. And the number that we estimated is a potential increase of 707 premature deaths across the 20 cities. And the last slide, it shows the impacts of public transportation or the public transportation scenario. It came out as quite positive, with a net benefit across the 20 cities of potentially preventing 970 or 74 premature deaths. Most of these prevented deaths, we would expect that they come from increases in physical activity, because we do include a component for the individual travelers walking from and to public transportation hubs. So there is an increase in physical activity there. But also, because public transportation is a relatively safe mode, we estimated reductions in road collision deaths and reductions in air pollution. Although I will say that there is quite a bit of uncertainty in the air pollution estimates, because they do rely on emission inventories in those areas, and we know there's some uncertainty in them. So we are looking more into this as well, and hopefully we'll be able to give an idea of what this uncertainty is in future work. So I have a couple more slides to show, and when Jeff asked me to give this talk, he was really interested in CO2 and climate change, benefits or co-benefits of potential transportation changes. We're looking at this still, so again, these are very preliminary results, but the other aspect of the benefit of these kind of different scenarios is what would happen to greenhouse gases. And in this graphic, I'm showing the differences in metric tons of CO2 between the baseline scenario, so things as they are, and the driving scenario, and then the public transportation scenario. We don't have results for the cycling scenario just yet, or results that make sense, so this will be added. But I think this is an important also element of the thinking here, and thinking about how many or how much CO2 or other greenhouse gases can we reduce by doing this mode shift, or with other transportation scenarios. And yeah, I think this is important. In the climate change literature, we call the public health benefits as co-benefits. This is showing an exercise that we did a couple of years back, where we looked at different changes in transportation. So one of them is here. You can see, I don't know if you can see my cursor, but it's the mode shift and transient efficiency, which came up as a really important policy option, or an option to reduce carbon dioxide, but also improve public health, which again, in the climate change literature, it's referred to as co-benefits. I think here we might have a different way of framing this, with the public health being central to our assessments and our discussions, and then we think about what carbon savings there could be as a result of these changes. But this is, I think this is an area that we're interested in looking more into, and is a really important part of the discussion as well. So this is my last slide. I just want to leave you all with some take-home messages. I think what I was trying to get across here is that transportation has a huge public health impact, and these impacts are preventable. We have ways of quantifying some of these pathways, as I've shown. We can quantify now with current methods and tools and knowledge the impact of 6 out of the 14 pathways, but most of the quantification work has been done in high-income countries. And in terms of solutions, I think a lot of us think that active transportation solutions has a really important role to play here. And while we need universal reductions in air pollution and the risk of travel injuries, they do have net public health benefits across the population. Public transportation has also a very positive role to play potentially, although at least in our work, there is still some uncertainty with the emissions from public transportation in some of these countries that we need to look into in more depth. And there are co-benefits to greenhouse gas emission reductions and climate change, which is a public health emergency. And these should be considered in those kinds of exercises. So with that, I will end and stop sharing and turn it over to you. Thank you.
Thank you very much. If there are questions, you can feel free to put them in the chat, and We have one question from Nicholas. Does this research mostly apply to urban areas?
The things I presented, yes. And I think part of the reason behind that is that there is a lot of urban population growth, and cities or urban areas are becoming like hotspots for a lot of these exposures, and therefore those health impacts or burden. That's not to say that rural areas are not important. I personally haven't looked into it, but everything I showed today comes primarily from urban areas, yes.
And then just a question about, did you account for the reduction in air pollution from increased cycling? Would that be large with the counterfactual shift?
We have. So yeah, the reductions in air pollution from the cycling scenario would be relevant for the population that doesn't cycle, and we did account for that. And then we also accounted for the increases in air pollution at the individual level of the biker or the cyclist. So these two things are there. Again, there is some uncertainty in the air pollution estimates, especially in those countries that are included in this exercise, because the emission inventories are not so well developed, and in some places they don't make a lot of sense. But we are looking into this, and we're working with the Joint Research Center and the European Commission to look into these numbers in a bit more detail, and get a better understanding of how they might look different if we use different emission inventories.
And a question about translating research into policies. Have you engaged with policymakers, and have you found it to be impactful in promoting urban planning policy changes?
I personally engaged some. I think some others as well. They perhaps engaged more. I know some of the tools like iThink Global, and there's another tool called the Propensity to Cycle tool, also from the group in Cambridge. They have been used in policymaking in the UK. That they're actually being used. Our results, like for example in Houston and in the States, I'm not sure that these have been used. Are they part of the discussion now? We hope so. But the good thing about them is that we are getting a lot of, like, I would say, general public interest in these results. So for example, the air pollution and asthma burden of disease assessment, when we did that exercise, we also created some interactive maps where people can go and zoom in to their county or their census tract, and find out how much air pollution they were exposed to, and how much that changed over time, and what is the attributable burden. And we found that received a lot of media and a lot of public reaction. Less so with policymakers, but definitely with the public.
And for the public transit, what were the fleet characteristics and emissions used? For example, was it assumed that you have a lot of older diesel buses, or did you assume you would have lower emissions with, electric buses, for example?
Yeah, let me share that. I think this is a big part of the uncertainty right now, but I do want to show how this looks like. So these numbers, they come from a project, really a big initiative in the European Commission in the Joint Research Center called EDGAR, which basically gives us gridded emissions by different modes of transportation. So these are our cities. These are the proportions of PM 2.5 emissions by different modes in each of these cities. So you can see car, and bus. These are the important ones, at least in this exercise. So in some places, like Buenos Aires, the cars are responsible for like 66% of PM 2.5, the buses 8%. These numbers depend, their emission inventories, so they do depend on the emission factors that are used in these countries, and in some places where there isn't information on the emission factors, I think the JRC or the Joint Research Center used emission factors borrowed from different places. So that's where the uncertainty comes in. But they're also based on distance traveled and the fleet mix. So yes, whether it's diesel or older diesel or electric buses should be taken into account here. I think this is a thing that we need to look more into. And I know that they have new emissions now that are more reflective of what happens in Latin America, which is again an area that there isn't, I think, a lot of data or enough data to enable exercises to the same level of rigor that we do in other countries, at least not right now.
Comment from James. It would be interesting to conduct a comparative study in Africa and understand the nuances driven by the context. Given transport and related data gaps in Africa, what do you suggest one can do if they would want to use and apply the IFIM model in Africa? In your view, do carbon emissions reduction solutions lie in policy, urban planning, or technology innovation and uptake?
So we are going to apply IFIM Global in Africa, and if you want to find out more about that application, please write to me or our leader James and Lambed. We're specifically working on the African application. And specifically, if you want to apply it in cities in Africa, we have some information for, I don't remember exactly which cities right now, but a couple of cities, including Accra and somewhere else, which I don't remember off the top of my head. So we'll have some results soon to share on Africa, and I think they're not very far off from what we see in other places. I think there is a consistent message that comes out from the different regions or the different cities. And yeah, I don't know if I'm 100% correct or accurate to say that the message is that shifts to active transportation will result in net health benefits, but we do need to do work on reducing, universally reducing air pollution and crash risk. So I think the other part of the question, I'm just looking at it right now.
In reducing carbon emissions, does the solution lie in policy, urban planning, or technology innovation?
Yeah, in my view, I think I would like to see it in policy and urban planning rather than technology innovation, because while technology innovation might reduce greenhouse gas emissions, they don't address a lot of the other pathways that we just talked about, and some of them are really important, like physical activity. It's a public health issue. So even if you use a technological innovation like autonomous vehicles or electric cars to improve certain aspects, they won't improve many other aspects. So I think we should think of like holistic solutions that hit on all these different pathways, and have public health as a central way of thinking about this.
Okay, great. I think that's all the questions. So once again, thank you very, very much for spending so much time presenting your research and the pathways between transportation and health. We really appreciate it. So good afternoon, everyone. And I think it's 6 o'clock where you are now. So Good evening, and thank you very much.
Thank you. Thank you so much.